So my research was influenced through personal exposure to a specific patient case and the medical team's unanimous decision to introduce the MACI procedure. So as this poster will dive deeper into the background of the patient's case report, the majority of my research was spent further exploring and analyzing the MACI implantation as a newly preferred surgical procedure and how exactly that would benefit an athlete participating at a very elite level of sport with every intention of returning to play. So I'd like to say and think that this poster is unique in a sense that it also coincides with current ongoing case reports. So as I was conducting my research, I was also spending the semester studying real clinical outcome measures and observing firsthand exposure directly to a patient who underwent this procedure. So first, let me introduce you to the MACI implantation. What is it, right? So MACI stands for matrix-induced autologous chondrocyte implantation. So a lot of words, but directly pulling out autologous, that means obtained from the same individual. So to put it in the most simplest form, the procedure entails the use of the patient's own cells to regrow cartilage. We'll go through the whole process step by step, but ultimately, by the end of the procedure, a cellularized scaffold of the patient's own tissue will be shaped, implanted, and used to repair partial or full thickness cartilage defects of the knee. So let's take a look at the step-by-step guide to the MACI process. So first, if the procedure is indicated, a biopsy is going to have to be taken. So a tissue sample approximately the size of about 2 Tic Tacs will be taken from the healthy cartilage removed from a non-weight-bearing aspect of the knee. So the most common harvest sites are usually the proximal, either medial or lateral femoral condyles. Second, the biopsy is going to be processed and frozen for the individual until the day of the implantation is decided. So lucky enough for us, this doesn't have to go too far. The state-of-the-art facility is actually located right in Cambridge, Mass. So then, once both the athlete and physician deem the timing's right for the procedure, the chondrocytes, or those cartilage cells from the biopsy, will be extracted from the sample, and then they're uniformly seeded onto a collagen membrane, which initiates that cell regeneration process, ultimately forming the MACI. So on the day of implantation, the MACI is delivered to the surgeon. The surgeon will then construct the sample into the exact size and shape to perfectly match their defect. So the MACI implant will be set in place using a ring curette, and then it's secured with fibrin sealant or like a surgical formation of glue. The implant is completely affixed to the area where the damage is, and then the regenerated cells combine with our body's natural proteins of the cartilage, and they form to repair tissue that matures over time and eventually restores the damaged cartilage. All really cool stuff. So the only limitations true to MACI as of today is its effectiveness on joints other than the knee, as well as its effectiveness on patients older than 55 years old. Things that we do know about MACI is that patients who receive the MACI implant must have the ability and resources to follow a physician-prescribed rehab program. So rehab should begin within hours after treatment. And in terms of our patient or the Division I athlete we're focusing on today, fortunately, that wasn't an issue. So let's look at the patient case report. His original injury took place during an in-season basketball game in January 2019. So the athlete went down claiming to have received a direct blow to the left knee from an opposing player. Upon initial evaluation, the knee presented with immediate swelling, absence of any locking, laxity, or catching, and full range of motion with limited pain. His functional activity could not be tolerated without discomfort. His chief complaint was kind of feeling as if there was stuff floating in the knee. So differential diagnoses that were discussed were possible patellar bone bruise and subluxation, just based off of the presentation. A lot of the signs and symptoms mimic the diagnosis of a bursitis, so that was discussed as well. And then lastly, due to that chief complaint of stuff floating in the knee, that's sometimes a telltale sign of what we call osteochondritis dissecans. So this led to referral for further medical imaging. Images that were produced from X-ray were unclear, yet the MRI and CT scans displayed floating bodies posterior to the patella, better known as osteochondritis dissecans. So OCDs is a condition in which the bone underneath the cartilage of a joint dies due to a lack of blood flow. The condition most often affects the knee, and it has a higher prevalence in adolescents. While most cases of OCD pain are gradually reported as intensity and workload increases, other cases, such as our patients, will also present as symptoms after sustaining an injury to that joint. So the initial procedural intervention, or in most cases, kind of the first line of treatment or management with this diagnosis, is a conservative general debridement paired with traditional rehab in hopes of a quick turnaround. And for him, that's exactly what they were looking for, in hopes that he would be able to participate in the following season. As live practices started and new stressors were introduced, the athlete's knee began to immediately swell up again. So this initiated further diagnostic imaging and coordination of a secondary plan. After the second MRI, the image displayed that there was still a very significant defect in the patient's knee. So recognizing that a secondary debridement would most likely just result in the same outcomes and ongoing issues for him in the future, the sports medicine team understood that there needed to be a better alternative. And this is what served as our indication for MACI. So the final plan was that the patient underwent MACI with a patellar realignment. So remember, as stated before, the importance of following a physician prescribed rehabilitation program after implementation is mandatory. So up here, you can see exactly what the patient followed. This is actually his exact protocol illustrated here. So progression throughout these 5 phases was very patient specific, in the sense that we progressed all accordingly to the phases of his tissue healing and the healing process. So he initially received treatment 7 days per week for 6 months. The pandemic altered his projected rehab plan a little bit, allowing him only 5 days of treatment per week from months 7 to 11 post-operation. As the institution he attends instilled a sense of normalcy once again, he returned to campus and received rehabilitation 7 days per week until he was fully cleared for participation. So the way that we kind of determined that, if we look down here at the return to play criteria, we depended mainly on these 3 things. So the HOP test, it's a test basically utilized to determine percentage-wise how equal you are on your affected side and unaffected side, to then progress you back to full contact return to play. So his running progression was allowed once he hit about 80% of his normal, while return to play had to be at that 90%. Girth measurements are normally used just to make sure that there isn't excessive swelling in the area. So those measurements were just compared to his baseline measurements. And then we also use serial confirmation imaging. So we did an MRI at 6 months and an MRI at 12 months, basically just to make sure that everything was progressing as the way that it should be, and that nothing was returning to the way that it had after that first initial debridement procedure. So the athlete was approximately 8 months out before he was allowed to jump, run, and cut in a controlled setting. That's about when he hit that 80% on that HOP test. He was cleared for basketball activity around 12 months. And that's when he hit that 90%. Yet we put a minute restriction for about 2 to 3 weeks following that on him, as well as mandatory days off post-game for that same increment of time. So he was fully cleared without a minute load and restrictions closer to about 13 months, and he appeared in his first game at 14 months.